Chapter 45 will discuss disorders of the female reproductive system. So I'm just going to start with sort of the stages of gynecological cancer because these will come up as we go through several different types. So just as a reminder, so stage 0, we rarely use this. These are pre-invasive lesions, usually pre-detectable. Stage 1 is when a cancer is confined to the organ it originated in. Stage 2 is when the cancer involves some structures surrounding the organ of origination. Stage 3 is when we have regional spread of the cancer to the lymph nodes, so lymph nodes within the same region of the original source. And stage 4 is when we have distant spread of the cancer with metastasis from the original site. There are a lot of different gynecological cancers. We can have cancers of the vulva, which are usually squamous cell carcinomas. We'll have cancers of the cervix, which we'll discuss more in depth. These are usually squamous cell carcinomas, primarily occurring in what we call the transformation zone. We have endometrial cancers or cancers of the uterus. These are associated usually with conditions that produce excessive estrogen. That excessive estrogen stimulates hyperplasia of the endometrium, which can lead to cancers. And then cancers of the ovaries. These are the most common and most lethal gynecological cancers. So we're going to start with a discussion on cervical cancers, and we will preface that with a discussion of the squamous columnar junction. We also call this the transformation zone, and this is an area of continuous cellular change. So this is the area where our columnar epithelial cells change to squamous epithelial cells, and this happens through metaplasia. And that metaplasia is being stimulated by things like hormonal changes, pH changes, long-term inflammation, and mechanical irritation. And you can see kind of from the picture, we have columnar epithelium kind of, deeper up into the uterus, and then squamous cell epithelium kind of in the cervix and down into the vaginal area. And so the junction between those two types of cells is what we call that squamocolumnar junction. The transformation zone is where cells are kind of continuously changing into squamous epithelium from columnar epithelial cells. So the transformation zone, you can see, kind of moves throughout the lifespan too. It starts quite low in the cervix at younger ages, and that is shown as B right here, a transformation zone, and then it kind of moves up higher up in the cervix, C to D, as people age. So again, that transformation zone kind of moves. During metaplasia, or that kind of change in cellular tissue, those newly developed squamous epithelial cells are more vulnerable to the development of dysplasia, or disordered growth and development of cells. And they're also more vulnerable to genetic changes if they're exposed to cancer-producing agents. So this is really a critical area in the development of cervical cancers. And it's also the area that we typically sample when we're doing pap smear testing for cervical cancer screening. So we'll discuss cervical cancer as an STD. So evidence clearly suggests that there's a causal link between HPV infection and cervical cancer. So things that are associated with increased risk of cervical cancer that support this hypothesis is early age at first intercourse, multiple sexual partners, promiscuous male partners, history of smoking, and history of STDs. Cervical cancer with HPV types 16, 18, 31, 33, and 45 seem to be the most prevalent. There are a lot of different strains of HPV that someone can become infected with. These appear to be the strains most closely associated with cervical cancer. Gardasil is the HPV vaccine that can prevent infection with HPV subtypes 16, 18, 6, and 11. So it doesn't prevent cancer of all strains, but these particular strains, HPV 16 and 18, are responsible for 70% of cervical cancers. So just by preventing those alone, we can prevent a really, greater than 50% of these strains from taking hold. The two most common benign strains, 6 and 11, account for 90% of genital wart uh, production. So this is a very good vaccine in preventing both genital warts and cancer-causing HPV strains. So cervical interepithelial neoplasial grading system. So this is the grading system that we use to kind of discuss the severity of cervical cell neoplasial changes. So CIN1 is mild dysplasia. So the cells still remain well differentiated. It's only the initial 1/3 of the epithelial layer that's involved. So this is relatively early. CIN2 is moderate dysplasia that involves the 2/3 of the epithelial layers with less well differentiated lesions. And CIN3 is more severe dysplasia or carcinoma in situ. So we would classify CIN3 as being cells that have lost differentiation enough to be called neoplasias, but they're still right at the site of development, right in the cervix. But they do have full thickness involvement with undifferentiated lesions. So pap smear cytological screening allows precancerous lesions to be detected and treated before cancer develops. So the CIN classifications describe pre-malignant changes to the epithelial tissues. So diagnosis of cervical cancer. So if caught early, this is the most easily cured of all female cancers. Deaths have decreased 50% over the last 40 years. Current recommendations for screening include HPV testing and cytology in women over 30 years of age. Cytology alone is recommended beginning at 21 years of age and then every 3 years until age 29. For women over 30, pap smear alone should be performed every 3 years or co-testing with HPV every 5. So those are the kind of the recommendations for pap smear. A colposcopy is a different medical procedure that we can use to kind of more closely examine the cervix, vagina, and vulva with a magnifying instrument. So we may use colposcopy if there is a positive pap smear to do a more thorough examination of those gynecological areas. We also do biopsy sampling of cells that appear to be abnormal. One type of biopsy is something called a cone biopsy. This is where we remove a cone-shaped wedge of cervix, and this includes kind of the entire transformation zone. The problem with cone biopsy is it can have a lot of possible complications, so it's really a procedure we would only do if entirely necessary. It can cause things like post-procedural hemorrhage, post-procedural infection, post-procedural pain. So just again, a complication-riddled kind of procedure that we try to reduce the use of if at all possible. The LEAPS or LEATS procedure is the more preferred method for management of things like CIN2 and 3 in patients. So this is an outpatient procedure. It allows for simultaneous diagnosis and treatment of dysplastic lesions that we find on colposcopy. It's an outpatient procedure where we take a thin, rigid wire looped electrode, and this electrode is attached to a generator that blends these high frequency and low voltage currents that kind of cut and remove the entire transformation zone. So this provides treatment for the lesion, and it also allows us to obtain a biopsy sample for histologic evaluation. Okay, so some clinical manifestations as well as treatment methods for surgical cancer or cervical cancer. So the presentation is often abnormal vaginal bleeding, spotting, or discharge. This bleeding is more prevalent after sexual intercourse. There may be pelvic or back pain that radiates down the leg. We may also see things like hematuria or rectovaginal bleeding or vesicovaginal fistulas. There may also be metastatic disease to the inguinal lymph nodes. So treatment is removal of the lesion by one of various techniques. So it might be local biopsy or local cautery. We may use electrocautery, cryosurgery, laser therapy. These are things used to treat moderate to severe dysplasia that's limited right to the exocervix. Um, if we have lesions that extend into the endocervical canal, we might use that therapeutic conization to kind of get deeper into those lesions. If cancer is more invasive or metastatic, we may need to treat with things like radiation, surgery, or both. Okay, so the next disorder that we'll talk about is moving up into the uterus, and we're going to start with endometriosis. So endometriosis is a disorder where we find functional endometrial tissue in ectopic sites. So you can kind of see on the diagram a lot of the areas where we might develop these functional endometrial tissues. So places like within the peritoneum, um, kind of right around here is our peritoneal lesions. We might develop lesions in the colon or around in the small bowel. They may also happen kind of on the outside of the uterus or in the fallopian tubes, just multiple areas kind of around in that abdominal cavity where we can develop this functional endometrial tissue. And when we say functional tissue, it means that it's estrogen dependent. So it'll go through the same changes as we would see in the normal uterine lining with fluctuations in estrogen levels. Okay. 10% of premenopausal women experience endometriosis, and that number increases to 24 to 50% of infertile women. So there's a close connection between the presence of endometriosis and infertility. Clinical manifestations usually appear in the reproductive years when we have that hormonal stimulation, but the underlying cause of this disorder is largely unknown. So again, these lesions undergo menstrual breakdown, and this menstrual breakdown can cause both pain and infertility. So lesions can bleed into the surrounding tissues, and they can cause what we term adhesions, where tissues kind of stick and sort of grow together. The symptoms are usually the strongest during the premenstrual period, and they usually subside for a time afterwards. Diagnosis of endometriosis can be difficult because symptoms don't always correlate with the extent of the disease. Um, but we often use things like ultrasound or MRI to identify lesions. We can also use laparoscopy, which is a surgical procedure combined with histology to test the tissues. Treatment is largely surrounding things like pain relief, where we might use things like NSAIDs. Endometrial suppression is often accomplished through maybe oral contraceptives or progesterone agents. We can suppress ovulation entirely for really severe cases, but this does cause a prolonged menopause, which also has kind of its own risks. And then there are surgical procedures. Sometimes surgery is to remove lesions or to um, correct things like adhesions, but we may also do complete hysterectomy for severe cases of endometriosis. Endometrial cancers are the most common cancer in the female pelvis. The majority of them, 99% of them, are adenocarcinomas. There are two major types of endometrial cancer. Type 1 is caused by prolonged estrogen stimulation and endometrial hyperplasia. And type 2 cancers are not estrogen driven. These are usually found in women postmenopausally at more advanced age, and they're typically associated with endometrial atrophy instead of hyperplasia. These tend to be more difficult to treat and more associated with mortality in endometrial cancers. The type 1 endometrial cancers tend to be more easy to treat. The majority, again, are hormone sensitive, and they're also really low grade and have favorable prognosis. These cells usually remain pretty well differentiated, so they're much easier to manage with treatment modalities. So clinical manifestations of endometrial cancer, things like abnormal painless bleeding, bleeding that occurs between periods or becomes excessive, prolonged menstrual flow, or any bleeding that occurs in a postmenopausal woman. Risk factors associated with the development of endometrial cancer, so things like unopposed estrogen. So unopposed estrogen is estrogen therapy given without progesterone. This used to be a more common type of estrogen therapy, but because of its link to endometrial cancers, we rarely give estrogen therapy alone now. We usually combine it with progesterone to prevent this type of cancer from occurring. Um, Progesterone in the second half of that menstrual cycle is really responsible for maturing the endometrium, and its withdrawal results in endometrial sloughing. So if we have long-term unopposed estrogen without that progesterone, this allows for this continuous endometrial growth and hyperplasia, which increases the chance of the development of atypical cells. Other risk factors, diabetes, hypertension, polycystic ovary, because these are all conditions that can alter estrogen metabolism and ultimately elevate overall levels of estrogen. Excessive fat consumption and being overweight are also important risk factors, again, related to their um, um, subsequent increase in estrogen and estrogen production. So diagnosis and treatment, typically diagnosis is done via endometrial biopsy. The prognosis really depends on the grade and type of cancer. As I mentioned, type 1 is much easier to treat because they're usually lower grade. Surgery and radiation are most successful in treatment here. But the overall survival rates, the 5-year survival rates for both type 1 and type 2 are about 83%. 96% if we catch this early. Okay, now we're going to talk about leiomyomas, which are uterine fibroids. These are benign neoplasms of the smooth muscle of the uterus. These are the most common type of pelvic tumor. They are often asymptomatic. Around half the time they'll be asymptomatic, and they just are discovered by happenstance on a routine pelvic exam. One of the biggest fears that women often have associated with fibroids is that they will interfere with pregnancy. But the reality is that they rarely do interfere with pregnancy, and most women who have fibroids are able to carry pregnancies to term. Most of the time, these fibroid tumors will regress or shrink with menopause. And removal is possible through what we call myomectomy, where we remove tumors, or through a procedure called intrauterine ablation. And both procedures really can preserve childbearing. There are different types of leiomyomas or fibroids depending on where they occur in the uterus. So we can have submucosal fibroids, and you can see an example of a submucosa right here, and then one that's kind of what we call pendulated or kind of projects out into the uterus. These are submucosal. Because these are in that innermost lining of the uterus, they do displace endometrial tissue. So they're more likely to cause bleeding and necrosis and infection than any of the other types. And these are also more likely to interfere with things like implantation of a fertilized egg into the uterus. So there is a bit of an increase in infertility with submucosal fibroids. Subserosal fibroids are located beneath the perimetrium of the uterus. So these are often irregular projections on the surface of the uterus itself. So this kind of over in the corner of our picture here is a subserosal fibroid where it kind of projects or juts out on the surface of the uterus itself. The final type and the most common type are intramural fibroids that are embedded right in the myometrium. So these are some examples here and here of intramural fibroids. And again, they're embedded right in the main smooth muscle of the uterus itself. So then we're going to move on to pelvic inflammatory disease. So pelvic inflammatory disease, or PID, is an inflammation of the upper reproductive tract. So it can involve the uterus, and you can kind of see that here, the fallopian tubes, we call that salpingitis, or the ovaries, oophoritis, okay? So essentially what we have is microbial infection that makes its way up from the vagina through the cervix, up into the uterus, and then can project itself into the fallopian tubes and into the ovaries. That's pelvic inflammatory disease. So it can be caused by a variety of infections and cause a varied array of infections based on geographic location and the type of infection involved. So there are some factors that increase a woman's likelihood of developing PID. Um, the most typical years where we see this develop are between the ages of 16 and 24. Unmarried women are more likely to get PID, women who have never been pregnant, women with a history of multiple sexual partners or previous history of PID, and also with the use of IUDs. This is because of the placement and the action of IUDs and its potential disruption to the uterine lining itself. This allows kind of more ability of microbes to kind of penetrate. The risk of this is relatively low, but it's not zero. So some clinical manifestations, diagnosis, and treatment of PID. So the most common clinical manifestations you see are lower abdominal pain, dyspareunia, back pain. We can see things like purulent cervical discharge, pain in the cervix, especially on pelvic exam. There may be a fever, elevated ESR, or erythrocyte sedimentation rate, which is a marker of inflammation. And we often have a co-infection with things like chlamydia or gonorrhea. Complications of PID include pelvic adhesions, where kind of surfaces of different pelvic organs sort of stick together. So one common area of adhesion is often within the fallopian tubes themselves. So with that kind of chronic inflammation caused by this infection in the fallopian tubes, those the tissues in the fallopian tubes kind of swell and kind of start to stick together. And so another really common complication of PID is infertility, because if you have significant adhesions in the fallopian tubes, you cannot, sperm can't pass through to implant with the egg can't pass through the fallopian tube, and so that leads to things like infertility. Another complication is potentially ectopic pregnancy, and this is also again related to kind of the scarring and things that happen within the fallopian tubes. This can narrow that fallopian tube opening and make it more likely for a fertilized egg to implant itself within the fallopian tubes, and that is what ectopic pregnancy is. Other complications are chronic abdominal pain and tubo-ovarian abscesses, so abscesses on the fallopian tubes and on the ovaries. The diagnosis is really made by looking at the clinical criteria that we just listed. If those are present, we go with a diagnosis of PID. We may verify this diagnosis via things like ultrasound, but it's not necessary. The treatment is through antibiotic therapy. This can easily be treated when choosing the right antibiotics. Oftentimes, though, PID progresses and causes long-term complications because of the lack of follow-up and treatment that we sometimes see. Antibiotics can either be oral for more mild cases, or for more severe cases, they may require inpatient IV therapy, or in cases where someone doesn't respond well to oral therapy. I had mentioned ectopic pregnancy as a potential complication of PID, and so now we'll talk a little bit more about exactly what an ectopic pregnancy is. So an ectopic pregnancy is a medical emergency. It is the leading cause of death of women in the first trimester of surgery. So we consider the possibility of a ectopic pregnancy anytime a woman of reproductive age presents with pelvic pain. Because it's such a serious condition, we check for it anytime those conditions are met. What's happening in an ectopic pregnancy is a fertilized ovum has implanted itself somewhere outside of the uterus, usually somewhere within that fallopian tube. Okay. Um, some things that predispose women to the development of ectopic pregnancy, as we already mentioned, PID or pelvic inflammatory disease, a history of therapeutic abortions, tubal ligations or tubal reversals. So women who have had tubal ligations or the reversal of a tubal ligation because of the scar tissue that might remain. Anyone who has had a previous ectopic pregnancy, again, because of scar tissue formation. Intrauterine exposure to DES. DES is a synthetic form of estrogen that we don't use too much anymore because of the risks that it presented. Infertility, and the use of fertility drugs to induce ovulation. So, clinical manifestations and treatment. So again, things like lower abdominal discomfort, it might often be kind of unilateral and radiating, and then that discomfort starts to progress to a more kind of severe pain. And this usually indicates progression of the underlying issue happening here, usually something like tubal rupture from that implantation of the ovum in the fallopian tube. Women also experience spotting, syncope, which is fainting or loss of consciousness. They may have referred shoulder pain, and this is usually from bleeding into the abdominal cavity. They may experience amenorrhea. They also have what we call adnexal tenderness. When we refer to something as being adnexal, it means it's a growth or it's pain that develops around the uterus. So usually kind of in the fallopian tubes or in the ovaries or in kind of the connective tissues around in that area. So that kind of makes sense, right? If we have an ectopic pregnancy implanting itself in the fallopian tubes, if we do an abdominal assessment where we kind of gently press in the lower abdomen, we may feel a mass associated with that, and we may have a patient with increase in pain. Diagnostics, we often do a pregnancy test, and a pregnancy test that is positive combined with an ultrasound that shows an empty uterus is often indicative of an ectopic pregnancy. Early ectopic pregnancy can be resolved medically by using methotrexate to end the pregnancy. But if it is later in this progression, like a more severe kind of progression of ectopic pregnancy, or if medical management is unsuccessful, we may need to do surgical removal of that ectopic pregnancy. And the goal there is to really to remove the ectopic pregnancy while also trying to preserve fertility. Okay, a bit of a discussion surrounding ovarian cysts and tumors. So cysts on the ovaries are the most common form of ovarian tumor. Disorders of the ovaries frequently cause menstrual and fertility problems. And cysts are often related to hypothalamic, pituitary, or adrenal dysfunctions that cause this kind of growth of cysts. I think cysts are often like um, follicles that fail to kind of rupture during normal menstrual cycles. So there's a lot of hormonal influence that can lead to the development of cysts. One type of cystic ovarian disease is what we call polycystic ovary syndrome, or PCOS. So PCOS, some of the common things that we associate with PCOS, one is infertility, also hyperandrogenism. So women with PCOS often develop things like acne or facial hair that is associated with this increased secretion of androgens. And so those are things like male sex hormones like testosterone. PCOS is often a common cause of what we call anovulation or anovulation. This is when a woman either doesn't ovulate or they go through a menstrual cycle and do not release an egg on ovulation. They often experience menstrual irregularities. They're often overweight. And some of the most effective treatments for PCOS are lifestyle modifications, so encouraging weight loss, dietary changes, and also maybe the use of oral contraceptives. The diagnosis of PCOS is often made after other endocrine disorders are ruled out um, in people who have oligomenorrhea, which is irregular or infrequent periods. So again, things like acne and excess body hair, elevated testosterone levels. We also can do ultrasounds of the ovaries, and what we're looking for is this kind of polycystic appearance where there's an ovary with multiple cysts. 50% of people with PCOS are obese, so there is a strong link between weight and PCOS. PCOS can cause some long-term health problems. Things like cardiovascular disease and diabetes are also often linked to PCOS. Ovarian cancer is the most lethal form of gynecological cancer. It is often lethal because it's usually diagnosed at an advanced stage, because many of the symptoms associated with ovarian cancer are really nonspecific, and they're difficult to distinguish from other kind of problems when someone might present to a primary healthcare provider. So the symptoms are often GI in nature. So things like abdominal bloating, early feeling of fullness, maybe mild abdominal and pelvic pain. And there are really no good screening methods for ovarian cancer either. Um, we had discussed CA-125 before. That does often become elevated in patients with ovarian cancer. However, its elevation can indicate a wide range of disorders, so it's really just not a very helpful screening method for ovarian cancer. We do know there are some risk factors associated with ovarian cancer. One is something called ovulatory age. And this is the overall time that an ovarian cycle is not suppressed, either by pregnancy or lactation or oral contraceptive use. We do see a decreased incidence of ovarian cancer in women with multiple pregnancies who have breastfed, or in women who have used contraceptives, especially contraceptives that suppress the ovulatory cycle. So that is how we've kind of made that connection between ovulatory age and ovarian cancer risk. As far as treatment, again, usually these cancers are often at an advanced stage when we discover them. And so initial treatment is often through surgery, and we use that to both debulk, meaning remove as much cancer as we can find, and to further kind of get a handle on the staging of the ovarian cancer. So while doing these debulking or cancer removal surgeries, we're also surgically kind of examining the lymph nodes, the other organs within the abdominal cavity, like the liver, peritoneal surfaces, because what we're looking for is anywhere within that abdominal cavity where this cancer might have spread. Ovarian cancers are really good at just kind of seeding themselves all over within the abdominal cavity, meaning just cancer cells sort of break off the original tumor, settle themselves into other areas, like either in peritoneal cavities or on the liver or other organs within the retroperitoneum, and just start growing new cancers. We can also use radiation and chemotherapy for treatment. I don't have numbers on the overall 5-year survival rate, but they are very low for ovarian cancer, especially cancer that's spread beyond the ovaries, which the vast majority of them do before they're detected. Now we're going to talk about the kind of ligaments and muscular support in the pelvic floor. So we have kind of 4 main ligaments that provide sort of the structure within the pelvic floor. There's the uterosacral ligament, the round ligament, the broad ligament, and the cardinal ligaments. And between those ligaments and the muscles of the pelvis, this provides this kind of strong sling-like structure that is meant to support pelvic organs like the uterus, the vagina, the urinary bladder, and the rectum. So over the course of things like aging and um, postmenopausal changes and changes to the pelvic floor muscle caused by things like pregnancy and the subsequent damage of childbirth through the pelvic floor, we can get a variety of disorders because of that pelvic floor weakening. One is something called a cystocele, and this is when we have herniation of the bladder into the vagina. So the weakened muscles that normally support the bladder cause it to sag below the uterus. And this sagging stretches the anterior portion of the vaginal wall, allowing the bladder to herniate into the vagina due to gravity and intra-abdominal pressure caused by things like sneezing, laughing, picking up heavy objects. A rectocele is a herniation of the rectum into the vagina. So this happens from the posterior vaginal wall, where the underlying rectum bulges forward due to pelvic floor and perineal muscle weakness, causing this rectocele. And an enterocele is when weakness in the area between the uterosacral ligaments, just posterior to the cervix, form this kind of hernial sac. And the small bowel can protrude into that hernial sac, especially when a woman is standing. Cystocele, rectocele, enterocele occur most commonly in multiparous women because childbearing is often accompanied by injuries to pelvic structures and to the uterine ligaments. So this picture shows several of the things we just kind of discussed. The picture all the way on the right, this is an enterocele, and so you can kind of see this herniated sac caused by those weakened muscles that's sort of protruding through the vagina, and then we have a piece of the small bowel that can drop down into that herniated sac. The picture all the way on the left shows a cystocele, so in yellow that is the bladder. You see it started to sag below the level of the uterus and bulge into that anterior wall of the vagina. The middle picture is a rectocele, where you have that posterior vaginal wall with the rectum kind of behind it, and now it's bulging into the vagina. The signs and symptoms associated with these various disorders are really related to the change in structure that we see. So with cystocele, many of the signs and symptoms are related to urinary issues. With rectocele, they're related to things like constipation and other bowel related kind of things. So again, symptoms are really related to the type of disorder. And we can also get something called uterine prolapse. And this is where the uterus prolapses or bulges into the vagina. So you can see that here. Here's the uterus, and it has prolapsed or dropped down into the vagina. And it can just be kind of sitting within the vagina itself, or it can even prolapse enough where it protrudes outward. Again, this is very closely associated with childbirth. We rank it by the degree of protrusion through the vagina. It can also be caused by things like pelvic tumors. It's more common in people with spina bifida. And people with diabetic neuropathy also have an increased incidence of uterine prolapse because it interrupts innervation of the muscles that form that sling and causes them to weaken. So treatment of pelvic support disorders. For some women, Kegel exercises may be helpful, but I think there's not a whole lot of great evidence to show that that has a huge effect. I think the amount of Kegels that you would have to do is more than most women are able to engage in. But there are also certain surgical corrections that we can do. These are often considered elective surgeries. They're usually not considered emergencies. And so if there's some degree of prolapse of an organ because of poor pelvic support, we usually wait until after childbearing years to perform any surgical intervention for correction. So this can include things like vaginal hysterectomy with vaginal wall repair, especially things like uterine prolapse. It can be vesicourethral suspension procedures, especially for things like cystocele. We can do abdominal hysterectomy with an anteroposterior repair. There are a whole host of surgical treatments. There are also a lot of new and kind of growing therapies that are within like kind of the physical therapy outpatient realm to work on increasing pelvic muscle strength to prevent any of these disorders from occurring in women who are at high risk. Okay, now we're going to move on to a discussion surrounding the menstrual cycle and some of the disorders that can occur in the menstrual cycle. So to start, we'll just go through a quick explanation of normal menstrual cycles and the influence of both estrogen and progesterone in that menstrual cycle. So the responsibility of estrogen is to stimulate egg follicle growth and to really build up that uterine lining each month. So you can see that estrogen levels kind of drop off after ovulation. So there's this steady kind of increase of estrogen all the way up until the point of ovulation, which is kind of right here. And so that is again preparing, while helping that egg follicle to grow throughout that process. And it's also building up that lining of the uterus. Once ovulation occurs, progesterone levels start to really drop off and they allow progesterone levels to rise. So progesterone levels really dominate during what we call the luteal phase, or that phase after ovulation. Progesterone really is responsible for preparing the body for pregnancy and also for maintaining pregnancy. So its rise and fall will also signal the body to shed uterine lining and triggering pregnancy. So you can kind of see that here, right? These progesterone levels really start to rise after ovulation. But if pregnancy doesn't occur and those progesterone levels don't need to stay high, they start to fall, and that leads to the overall shedding of the uterine lining. So these are some terms to be familiar with when we discuss dysfunction of menstrual cycles. Amenorrhea is the absence of menstruation. Hypomenorrhea is scant or small amounts of menstruation. Oligomenorrhea is infrequent menstruation. Polymenorrhea is frequent menstruation. Menorrhagia is excessive menstruation, so that's really heavy periods. Metorrhagia is bleeding between periods. And menometorrhagia is heavy bleeding during and between menstrual periods. So just some terminology to be somewhat familiar with. So these are also terms associated with the large category of abnormal uterine bleeding. So heavy menstrual bleeding is regular menses that lasts a week or more, or bleeding that's greater than 80 milliliters per cycle. And we sometimes gauge heavy bleeding by maybe how many tampons or pads someone changes within an hour, but this is some of the definitions of heavy menstrual bleeding. Light menstrual bleeding are regular periods, so they come on a regular basis, but the flow is extremely light. Intermenstrual bleeding is bleeding that happens between periods, usually with a pretty light flow. Heavy irregular bleeding is prolonged or heavy bleeding that occurs at really irregular times. Infrequent cycles are cycles that are irregular and occur greater than 35 days apart. Polymenorrhea are cycles that occur on a regular basis, but they're less than 21 days apart. Primary amenorrhea means no menses and no secondary sexual characteristics by age 14, or no menses by age 16 with secondary sexual characteristics. And secondary amenorrhea is an individual that has had a menstrual cycle and then ceases to have them for a period of at least 6 months. Again, some overall terminology related to abnormal uterine bleeding. So abnormal uterine bleeding etiology and pathogenesis, this is usually related to some sort of alteration in those underlying hormonal levels. So one potential is estrogen deprivation, and this usually causes irregular bleeding, irregularity in both the amount and the duration of menstrual bleeding. And this is because that estrogen deprivation causes sort of a regression of that uterine lining buildup. And so that normal kind of regularity in amount and timing of bleeding is not present because we don't have that kind of normal building up and shedding of uterine linings on that kind of normal schedule when we don't have that steady increase and decline in estrogen. Low progesterone levels can cause abnormal menstrual bleeding because this allows estrogen to predominate. If we have more estrogen than progesterone, this causes an overall increasing of the thickness of the endometrial layer and its blood supply. So low progesterone often leads to things like an increase in amount and timing of menstruation. If we have deficiencies in both progesterone and estrogen, this can lead to what we call anovulatory bleeding, where we have menstrual bleeding without the release of a follicle or no egg release, anovulatory. Usually with anovulatory bleeding, we have an absence of cramping, so usually kind of painless periods, but there's also a really heavy flow. This type of bleeding is most common in adolescence, so really early in menstruation. It's also relatively common in perimenopausal women because we're starting to see sort of an overall drop off in all of those progesterone and estrogen levels. And it also happens more frequently in women with PCOS. Many women also experience pain with their menstrual cycle. We term this dysmenorrhea. It's often secondary to other organic conditions, so things like endometriosis or fibroids, adenomyosis, which is tumors of the uterine muscle, pelvic adhesions that are sometimes associated with things like PID can lead to dysmenorrhea. The presence of an IUD or the presence of PID are often linked to dysmenorrhea. These are usually treated maybe with analgesic agents like over-the-counter stuff like NSAIDs and Tylenols, and sometimes with the use of contraceptions to sort of suppress the hormonal changes during the menstrual cycle. PMS and PMD. So PMS is premenstrual syndrome and PMDD is premenstrual dysphoric disorder. This is very common. 80% of menstruating people experience PMS. And the incidence of PMS and its severity typically increase with age. So the cause of PMS is multifactorial. Previously, we linked PMS to things like endocrine imbalances. So hormonal imbalances were thought to be the main cause of PMS. Through research and more recent studies, we're kind of rethinking that now to suggest that hormone levels are probably normal for women experiencing PMS and PMDD, but it's the reaction of the female body to these hormones that is abnormal. So common clinical manifestations: painful swollen breasts, abdominal pain and bloating, headache and backache are common, as well as things like depression, anxiety, irritability, and behavioral changes. So to diagnose and treat, good history and physical is necessary here and often directed at excluding any other either physical or psychological cause of PMS or PMDD. The focus is really on identifying symptoms that we record on like a daily calendar. These symptoms would need to occur around menstruation and last for 2 to 3 consecutive months. PMDD is really a psychiatric condition, and that helps to distinguish it as being more severe than PMS. And it's typically severe enough to interfere with daily activities. The diagnosis of PMS only requires one accompanying symptom, and the diagnosis of PMDD requires anywhere from 5 to 11 symptoms to be present. Again, speaking to kind of the increased severity of PMDD. Treatment of PMS is largely surrounding lifestyle changes. So lifestyle changes can include things like personal assessments, like keeping a diary of menstruation and associated symptoms. Often this can help alleviate symptoms where, women are, I guess, kind of psychologically prepared for them and can identify kind of any like physical or psychological changes as being PMS related. And that sometimes kind of increases their sort of ability to cope with those symptoms. Other things that can help lifestyle wise, things like regular exercise, avoidance of caffeine, reducing simple sugars in the diet, adding in things like lean proteins. Those are all some lifestyle modifications that can help. Some women also find some vitamin and mineral treatments like vitamin E and magnesium supplementation to be helpful. We sometimes use diuretics, especially for women with maybe severe bloating or fluid retention with PMS. We can use analgesics for like things like headache and back pain. Contraceptives can sometimes reduce the symptoms of PMS and PMDD. And SSRIs have actually been found to be very helpful both in the reduction of PMS symptoms, physical and psychological, and the reduction of PMDD symptoms. Okay, now we're going to move on to disorders of the breast. This slide just gives some kind of terminology of some of the general disorders, and then we're going to talk specifically just about breast cancer. So galactorrhea is secretion of breast milk in non-lactating breasts. So this is an abnormal condition where we would have secretion of breast milk and someone really not expecting it. Mastitis is inflammation of the breast. Mastitis is most common in lactating women where we have either a block in a duct that's preventing the removal of breast milk, or we have an interruption in breastfeeding that allows for the kind of accumulation of breast milk in the breast. Ductal disorders, these are things that can lead to kind of gray or green discharge from the nipples. A fibroadenoma is a firm, rubbery, sharply defined round mass that we sometimes find in breast tissue. Fibrocystic breast tissue is breast tissue with these kind of nodular, granular breast masses. People with fibrocystic breasts can make it much more difficult to like screen for and watch for things like breast cancer. So people with fibrocystic breasts might need more frequent like mammography and other type of breast cancer screening. And finally, breast cancer. This can be masses, puckering of the breast, nipple retraction, or unusual discharge are usually kind of the signs and symptoms associated with breast cancer. So breast cancer is the most common female cancer. Some of the risk factors include sex, so only 3% of breast cancers happen in men, and age. Breast cancers become more common as women age. Things like history of breast cancer or some of the benign breast diseases. There are hormonal influences, so many of the breast cancers that we discover are their growth and of those tissues is estrogen driven. Obesity is linked with an increased incidence of breast cancer. There is an increased incidence in people who use long-term hormone therapy after menopause. There's also an increased risk in people who consume alcohol and those who are physically inactive. But I will say that the majority of people who develop breast cancer have no identifiable risk factors at all. So this is really not kind of the whole story. So with breast cancer, we really focus on good and effective screening. So part of that is potentially through physical examination, again, looking for some of those common clinical manifestations of breast cancer, including masses in the breast, puckering of the breast tissue, retraction of the nipple, or any unusual discharge. So women are encouraged to kind of be self-aware of their breasts and to potentially perform breast self-examination. We usually encourage BSE after menses for premenopausal women, but it can be done anytime for those who are postmenopausal. Usually, though, when women discover a breast cancer, it's usually outside of that scheduled breast self-examination time. So the American Cancer Society screening guidelines really emphasize breast cancer diagnosis on mammography and really encouraging women to just kind of be self-aware of their breasts. BSE can be helpful, but it's not the time when women usually discover issues with the breast. They're usually discovered at other times. Um, we also recommend that women go in for clinical exams for breast cancer every 3 years between the ages of 20 and 40, and then annually after 40. Mammography is also a really good screening tool. It has a sensitivity of about 80 to 90%. For women of average risk, we recommend mammography usually every 2 years between the ages of 40 and 74. But I will say there's not complete agreement on this, and those recommendations do change kind of frequently. And now we've really added in this concept of risk. There is a structured risk assessment that we now use going along with mammography screening that gives people a percentage of risk. And those who fall into a low percentage category will have different recommendations than those who are in some of those higher categories. Diagnosis is usually by ultrasound with some sort of biopsy, whether it's a percutaneous, so through the skin needle aspiration, or a stereotactic guided needle biopsy, or more of a surgical or excisional biopsy. But we do need to collect some sort of tissue sample from that breast mass to look at histology of that tissue. So treatment of breast cancer, we can have surgical treatment. One form of surgery is what we call a radical mastectomy. That involves removal of the entire breast, all the underlying muscle of the breast, and all the axillary lymph nodes. This is rarely now the primary surgical therapy unless we have cancer that is really advanced at time of diagnosis. We usually use more kind of modified surgical techniques, so maybe just a basic mastectomy with maybe some axillary dissection, or even just lumpectomy if that mass is really confined to the breast tissue. And that helps to really conserve breast tissue without the need for extensive reconstruction. We can also use chemotherapy and radiation, and we often use those in conjunction with surgical treatments. They often have comparable outcomes. So it's really just kind of preference or advancement of the disease that decides which route to go. We can also do hormonal manipulations. As we mentioned previously, these breast cancers are often the growth of those tissues are often stimulated by estrogen. So for many women who have those kind of estrogen stimulated tumors, we will block estrogen. So we'll almost put them into a postmenopausal state to prevent the recurrence of breast cancers. Prognosis of breast cancer is usually related to the extent of spread and also to nodal involvement. So the more nodal involvement, the more spread, the more progression at time of diagnosis, also speaks to poor prognosis.